Zofia graduated as a homeopath from the UK Northern College in 1985 and has managed a private practice from home since then, while also contributing to the development of the profession in a variety of roles with the UK Society of Homeopaths board for over 21 years. It's pretty amazing. Being an assessor, mentor, and supervisor for the Society's registration program has allowed Zofia to focus on the benefits of peer supervision, which has culminated in her facilitation of many workshops on this topic. So I guess that last bit's very relevant to tonight's session. So I hope everyone enjoys the session, ask questions, and Zofia, take it away.
Okay, thanks, Raleigh, for that warm welcome and introduction. That's great. Yeah, I'm a UK homeopath who also, I have family in Australia, so I have a foot in both countries. I come over to Australia regularly, and it's a pleasure to get to know homeopaths, naturopaths, and other complementary practitioners as I go to conferences and attend seminars and so on in Australia. So it's a pleasure for me to do this seminar for Endeavour, this webinar on how peer supervision can help you in your day-to-day practice and what added value it brings to that, the very real, and I know as well as anyone, having been in practice for 30 plus years, I guess more years than I like to think of, the reality of managing a practice. And so this will show how supervision helps share that load. So that S word, supervision, I know homeopaths and other CAM practitioners have different ideas about what it means, how it works, and what is involved. So I'd like to begin by throwing the discussion open and asking people to come back, if you would, and say, what do you think supervision involves? So,
I love it, Zofia. You're keeping us honest straight up. So, if anybody's got would like to help us out
yeah,
with a response there, please just type it in. That'd be great. What I didn't mention
yeah.
while people are typing that away, Zofia, what's your time zone at the moment? Where are you, and what time is it there?
I'm at 8:30 in the morning.
Oh, that's so you're about starting the day.
Yeah,
So we're a bit different here.
civilized, actually.
Yes,
Yeah, yeah. I know it's the kind of early evening for
that's
eat
the
at
twilight.
home.
Yeah.
Yeah, yeah.
Um, I haven't received anything.
Okay.
Kimberly's come through with a second eye.
Yeah, yeah. Good one.
Yes.
Yeah, but that ties in really well with the whole concept of supervision and the meaning of the word itself, because supervision does exactly that. It gives us the opportunity to step outside the circle where we manage our day-to-day practice and take a look take a look back from outside about what has happened. And it's not necessarily about the right treatment, whatever modality you practice. It's the opportunity to look not only at how did I select the treatment, but the process of what went on in the consultation and what issues were flagged for your client, but also what wider issues were flagged for that. So a colleague of mine, Sheila Ryan, describes supervision as an inquiry into practice, and not only an inquiry, but a compassionate and appreciative inquiry. So that opportunity to cast that second eye, exactly, Kimberly, that's a good one.
We've also
Yeah,
got Francesca, who's come in. Thank you, Francesca and Kimberly. Francesca said, guidance, opportunity for discussion, making mistakes in a supported environment.
yeah, yeah. Yes, because again, that I'm a very pragmatic kind of feet on the ground practitioner, and I think we all acknowledge that there's no such thing as the perfect treatment in homeopathy. That might be the remedy, naturopathy, the right, exactly the right guidance for that client. We obviously have our skills and experience, our training, our education, but it's like, okay, how did I get there? And did I handle that as well as I could? Would I look back on my case files 5, 6 years, I sometimes take a dip in my filing cabinet and think, okay, why did I miss that? So it's the opportunity to acknowledge, yeah, we can make mistakes and we can review that. And that is the same for almost any profession. I gave a webinar recently to the Australian Homeopathic Association, and I just heard a radio program where a pilot, and I didn't know if I wanted to hear this given I do a number of long haul flights in a year, where he said they do log mistakes that they make during a flight. And of course, they log it because they need to know, the airline needs to know, and it's all about safety of our clients. The bottom line is we're all doing this so that our clients benefit from our treatments. And so in the end, it's in the interests of our clients, and it helps us grow and mature as practitioners on that road. And a very important aspect of supervision, and particularly peer supervision, which is what I'm going to be talking about later, is how we develop that sense of community, and how we find it, and how peer supervision can support us to find that. And there's a very good rationale for that. There's a study into CAM practitioners in Australia that shows that in that particular study, nearly 48% are in sole practice. And I don't know how that is for you guys out there. Do you practice on your own, or do you practice as part of a team of other practitioners in your same therapy? Do you practice as part of a wider CAM clinic? Or are you out there practicing on your own, either from home or from your own clinic?
It's a good question to ask because a lot of our graduates, just from the graduate destination survey type, and the information that we receive as a college, they go in all those areas. So it's just a matter of depending who's with us tonight. But please
Yeah.
share with
Yeah.
us what your current business operations are, whether you're working in a multimodality clinic at home, and it'd be interesting to see.
Yeah.
Just it's that time. So
Yeah. 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 And I think it's interesting to get that information
mhm,
because it gives us an opportunity to consider what sort of support mechanisms we need to have in place as practitioners
mhm.
to strengthen, our professional.
And there's two.
Uh,
We've Kimberly's mentioned that practices on their own, and Francesca's come back with a great point. I don't practice, so we've got to always remember a lot of people who study go on to other career paths with their degrees. So I'm not sure, Francesca, where you're at the moment and what yeah your role is, but I mean that's something that I'm always conscious of with our graduates. Janet's come in with sole practitioner practicing from home, so. Yeah, I think there's a lot of students when they're studying have the intention of going through and starting up their own business, but may not go there um, in the first place. Are you still there, Zofia? Just seem to have frozen at the moment. Okay, it just seems that we might have a technical hitch at the moment. Could everyone? I can see everyone who's still online. Could you just select the raised hand button just so I can see that you're still online? I think Zofia's just left us and she's coming back. Thank you, Kimberly. Yeah, there's no sound and image of Zofia is gone. That's correct, yes. And coming back. We'll just wait.
Hi, Raleigh.
Yes, hi.
Yeah, yeah. I lost connection for a moment, and now it's
Okay,
come on again.
no
Sorry about
problems.
that. Yeah,
It's okay. I can hear and see you, and you've just bringing up your presentation now. Um,
yeah,
so yeah, so
yeah. Yeah.
I'm getting the
So
same
I,
information back, so hopefully, if people can't see and hear you, they'll definitely respond. But I think it's just back to where you were.
yeah, I hope it doesn't happen again.
Yes,
Technology is great when it works.
yes,
So I was talking about the reference point, so the Australian competency standards for healthcare workers, where it's written in that reflecting and improving on your practice via open and evaluative feedback to and from your co-workers, and actively seeking feedback, and the capacity to accept it non-defensively. So that's in those competency training standards from the Community Services
yeah.
Health Industry Skills Council.
And I guess that can
So
be a hard part of the process, the non-defensively, like to get it because you want to improve as a person and
yeah,
in all aspects of the business, but not to take it on board as a harsh criticism. It's yeah, so
yeah, yeah, it's not meant to be undermining.
mm,
It's when Francesca said earlier, it's about learning from our mistakes, or mistakes is an odd one. It kind of suggests that there's a right and a wrong, but learning as part of the process of real life practice, and the fine tuning of it perhaps is a
mm,
word that I prefer than mistakes, because that suggests that there's a right and a wrong. And I think we all like to do our best for our clients, and we obviously do at the time, but the capacity to be open to learn and receive feedback. And that's not necessarily either somebody saying you should have done it this way, which, talking to CAM practitioners, I often think they're a bit hesitant or averse to supervision because they think it's somebody going to be telling them what they should be doing. And that's not what it's about. It's about that open inquiry, that capacity to evaluate what we did and to receive that evaluative feedback from our colleagues, and absolutely rally
mm,
to accept it in the open and we're all learning together mode in which it's offered. And yeah, that does mean a level of confidence and trust, which again the frame for peer supervision can help offer. So supervision itself has many disguises. It comes in many forms. And I was interested to read an unpublished dissertation from Alistair Gray, who I know does also present for Endeavour. He's got quite a key role at Endeavour College. He's a homeopath. And he did a study of what actually makes thriving homeopathic practice for practitioners in Australia and New Zealand. He did a small study of practitioners who identified themselves as having thriving practices. And he chose the word thriving deliberately because we all have different levels of what we consider our needs are financially and what makes up a successful practice in terms of client numbers through the door every day, every week. So these practitioners identified that they had a practice that was thriving. They were satisfied with it. They earned enough for their own needs, their family needs. Their individual contexts are all different. And when, during the interview, they all identified people both in their personal and professional lives that filled a supervisory role. And nonetheless, they all had a reluctance to describe what they prefer to call debriefing or downtime or working with peers as supervision. So I'm kind of interested to explore that, what it is about the word supervision that is a bit touchy for some practitioners, and actually it's something that can add a huge amount of strength and confidence and add to our skills and our knowledge and our understanding of what we do in day-to-day practice. So yeah, another question. really, opening it out, a bit like that, as you gathered, where do we find a place to reflect on practice? What context can that reflection take place? So when Kimberly says it, that second eye on our practice, do any of you actually have a place? And it may not be formally called supervision, but do you have a place where you realize that, oh yeah, that's where I do the debriefing? And for some it can be, a cup of coffee with a colleague. For others it can be a long bike ride on their own where, it all ticks over in the head and you can come back to refreshed to practice. I know Alistair said in that dissertation, in that study, one practitioner said that she drove, long drive to a seminar or a conference with a colleague, and in that conversation during that journey, that's where their peer supervision took place, although she didn't formally identify it as supervision. So the many disguises of supervision can be formal, they can be formalized, or they can be informal and provide the same role.
Yeah. And you mentioned an interesting point when you asked the question. I was thinking, okay, with the words reflection, I find that a very personal word, so it's reflecting. So, but then I guess once you've reflected, if you at that point, I think you look for key indicators, would you, to see if you're not solving it yourself during that reflection, then you can look for further assistance. But I mean, that's just how I looked at it.
Yeah, I think, that's a very good point, Raleigh, that reflection often is the place where you on an internal basis, on personal basis, you kind of look at how your practice is, what's happened, whatever it is, and it's then what you do with it. Because it's so, I know some people can get into a bit of a loop of, oh my God, for instance, I know years back when my first patient had to use antibiotics for a child, I went through a huge internal, oh my God, I failed as a practitioner, as though, homeopathy was going to answer every client's needs on every occasion. And that's not actually a reality. I don't now expect that homeopathy is going to meet everybody's needs. Yeah, it's what I do and it's what my aim is, but recognizing that for some patients it's not going to work, and if there, as there was in that case, a very young child with a temperature that was rising and an infection that was getting worse, antibiotics was actually the right thing at the right time for that child. But for me, I had to let myself off the hook of I've failed as a homeopath and recognise that it was that parent's choice and it was a necessity.
Yeah, okay, great. I've got from Kimberly's come in regards to the where could reflection take place is a logbook, pro-con after each consult, colleagues, and then in old clinic, if the same client with client consent would review case with colleague in similar field and see different approaches, and the helpline as well.
Yeah. So all of those are different contexts, and depending on who you are, you'll have different things that really work for you. And for some, a logbook, or what some people call their practice journal, where they do a bit of reflective writing, either every day or every week or once a month, and we'll talk about those different possibilities later on in the webinar. But yeah.
And Kimberly finished with even trying client feedback forms as well.
That's a really interesting one. That's a good one, because there are two ways of, two aspects to that. One is that if patients use self-evaluation forms, then you already have a built-in structure for clinical audit. So you then have a way of monitoring how your patients monitor their progress and their response to the therapy. So that, because I know that we, often we're so busy seeing people that we don't have an opportunity to build up the evidence base that really needs in this world of evidence-based medicine, where the demands are, okay, where's the research? And I think, again, Alistair Gray gave an interview a while back now where he's saying, we as CAM practitioners, we don't often have or always have, or hardly ever have the opportunity to have the funding that will give us the opportunity to do a random controlled trial or even a qualitative study into how homeopathy or naturopathy or acupuncture is doing, either for a patient group or for a particular condition. But what we do have is that wealth of clinical evidence that we're accumulating in our practice, and using patient evaluation forms is a very simple way of actually patient-centered research. It gives us a very valuable research. And some practitioners will also build in an aspect of asking the patient to say, well, what worked well in that consultation? What didn't work so well? And a lot of that is often about the sort of information that patients get about what to expect from the consultation, and whether they come to the consultation ready to make an informed choice about the treatment on offer. Because I think we're often, again, very practice-centered, and asking patients to evaluate how the consultation went gives us, again, a very good information base that helps us as individuals, but also helps the profession in a wider context. Yeah. So, good point. So, reflection. That, as Riley said, often it's a personal space, and it can also be that more formalized space. Reflective journaling, patient evaluation, work with peers, and teamwork in clinics. And a lot of that centers around the therapeutic relationship, what actually happens between the client and yourself as the practitioner, what psychotherapists would understand to be the therapeutic relationship. But it's not just limited to counselling and psychotherapy, the talking consultations. It's whatever happens when you're in a room with a client, you're in a relationship with that client. And I don't know if any of you, it's been big in Europe. There's a Scandinavian novelist called Henning Mankell who writes detective novels based around a detective called Wallander that's been dramatized for television. Some of you may know it, some of you don't, maybe. But as well as being a novelist, he's a patient who developed lung cancer a couple of years back. And he agreed to write a log of his treatment for a national UK newspaper. And when I read his description of what he wanted, or what he found as the most useful in that doctor relationship, I found it very interesting that he said medication and other treatments are never enough in themselves. So it's not just about the needling in acupuncture. It's not just about the vitamin regime for naturopath clients. It's about communication. It's about that relationship. The patient needs to understand what the doctor or the therapist is saying. And the doctor needs to remember that it's about the patient, not about what they believe is best for the patient. So all of us need to be willing and able to put the patient in the center and say, okay, this is someone who's come for a consult, whatever it is, whether it's homeopathy or acupuncture, or we know what we're about, but does the patient really know what's involved? Are we really able to put the patient in the center and allow the patient to say, okay, is there anything else that I can help you to understand what's involved in this treatment? So I thought that that dialogue that's at the heart of treatment is very, very important for all of us healthcare practitioners. And, you know, this is someone who's undergoing very conventional treatment for his lung cancer, but recognizing that alleviation, consolation, and perhaps even cure always involves that dialogue, learning to talk to each other, to listen, and to feel that we're heard, so that we're not putting the therapy ahead of the patient. So we're allowing the patient to inform a patient-led practice. So I often hear practitioners talk about, oh yeah, I know that this patient will benefit from a treatment, you know, that involves perhaps something that's not real for that patient, going back to, you know, the baby who needed antibiotics, or, you know, the patient, say, who finds that they just cannot take those Chinese herbs that the TCM practitioners think are going to be good for them, and actually they can't take them. You know, they can't build it into their day. They find it very hard, literally, to swallow. So we need to be able to adapt our treatments depending on who that patient is. So any comments on that one?
I think at the moment, Zofia, everyone's taking all the information in, and yep,
We're going.
we'll get some questions at the end.
Yeah, sure. Yeah. So that active listening is something that we need to put at the heart of our day-to-day practice. And supervision, peer supervision, one supervision, even that reflecting journaling will help fine-tune that listening, that capacity to be more present for each patient as they turn up in the consulting room. And again, that quality of looking, which comes back to what Kimberly was saying about that second eye, that widening our perspectives of what happens in our practices. And reflection, you know, it's not airy-fairy, it's actually learning from day-to-day practice, including something that in conventional terms might be described as a critical incident, something that unusual that happened, something that made your alarm bells ring, something that you needed to refer back to your code of ethics about. And there is a very formalized way of taking that personal reflection that Raleigh described into an active process with real outcomes that helps widen your understanding of the situation and highlighting what you might actually need to develop. Sometimes reflective practice will allow you to think, okay, I need to actually go up and read about a particular aspect of practice that you've neglected, or that you've heard a colleague describing a patient consult has actually made you realize that it might be relevant for that patient at that time, and you need to go off and do some CPD on that. So, and again, this is something that is common not just to CAM practitioners, but to any healthcare practitioner. So that thoughtful practice, again, this is, I think, an Australian nurse practitioner who writes about reflective practice in nursing. So planning actions using theory and monitoring those actions consciously. So in what somebody called Gibbs devised as a reflective cycle, you can take that, you know, whatever happened, and maybe this is something that you can experiment with after a patient consult, where you can say, oh, actually, what happened in there? So you describe it. And sometimes that might be something that you do on your own, or it might be something that you do either with peers in a peer support group, or in one-to-one supervision with your formal supervision framework, where you say, so I would have gone to my supervisor with the patient who needed antibiotics, that baby, and I'd have said, okay, there was this patient who needed antibiotics and I feel I failed, or the patient who was having an acute mental health breakdown where the homeopathy didn't actually prevent her from being hospitalized. And I went through the same loop of, oh, okay, I failed and homeopathy has failed that patient. So describing that, what actually happened, and then actually owning my feelings, my responses, my internal responses to why, I felt I'd failed. So just putting it out there, okay, yeah, I feel I failed big time, but not just stopping there. If I think back 30 years ago with the baby, I just gave myself an internal hard time for quite a while. But later, bringing it to supervision, I was able to use the some leading questions from our supervisor to analyze those feelings and recognize that it was a lot to do with my self-belief that homeopathy was going to help heal the world, like no pressure. And actually do a bit of a reality check on that one.
Sure.
So
Zofia, have you been in a situation where going through this cycle that you're talking about, say, and it's more of a peer group session that you're having, and you're just doing the reflective activity, and you're saying, well, this is the situation, this is how I dealt with it, and this is the outcome, and you could say that for whatever reason that you weren't happy with the outcome. Have you been in a
yeah,
situation where the person or people within that group say, well, you did everything right, we're not, and they've agreed with you, and you've needed
yeah.
more support? Like, what would happen in that situation?
Whether people did agree with me, you mean,
Oh,
or
they agree with what you did and everything, but that's just the outcome
yeah.
that's happened. But or if there's or have you been in a situation where you've actually needed more support, is what I'm saying, from even the peer group that you're in?
Yeah, sometimes what I've needed to do, well, it is actually go what I said earlier about
Hmm.
identifying, actually I just need to read up a bit more about this
Hmm.
condition, or I actually, with the case of the patient with the mental health problem,
Hmm.
have a constructive dialogue with the community psychiatric nurse who was also caring for that patient. And, so depending on the patient, you might find that there's other professional help that you
Yep.
will need. So talking to the community psychiatric nurse, the CPN, I was able to again, it was a bit of a reality check to recognize that actually this woman had an acute episode. I thought that homeopathy had failed because she did
Mm.
need to be hospitalized, she did need medication. But what the
Yes.
CPN was able to say was, actually the episode was shorter lived. It wasn't as intense because she knew her wider history, her wider mental health history, and say,
Sure.
I, yeah.
Yep.
So
And I guess that would be dealt with in the action plan. I'm probably jumping
yeah,
in there because
yeah,
it would be okay. Well, this is the research we need to do and to find out further. So that's good.
yeah,
Kimberly's come in with a question, just saying, um, is there a process or framework within this cycle of supervision or reflection that can allow you to better have that second non-judgmental eye?
yeah,
That is
yeah,
truth. Uh, there's a bit more. There's that is truthful and helpful as supervision in whichever form seems subjective to your view and
yeah,
inner
yeah, yeah,
critic.
yeah, yeah. What I'm going to do later on
Mm,
is describe something that it's a very useful framework in peer supervision called working in triads. So we'll come to that later. So that
excellent.
I
Okay.
think that is a very useful frame for doing exactly that, Kimberly.
Excellent.
So
Okay.
yeah. So, yeah, just looking at Michael Carroll, who's a psychotherapist who also does supervision. So it's that review and reflection in order to do better. So peer supervision, which is what I'm particularly interested in, because it really does help create a strong and confident community of practitioners out there, out here, where all of us are in practice. It offers the forum to discuss ethical dilemmas, identify common problems, because often we think, oh, it's just me with that issue, and also developing group rapport and emotional safety, both individually and as a group. I don't know what it, for you, but certainly in the UK, at different phases, there has been a real sense from members in our professional associations that they're out there on their own in practice, and that culture is shifting, and it needs to shift, so that we develop an ethos of working with our peers and supporting each other in practice. And I think for some people, we also have to own that it's about commercial competition. That there's a bit of, maybe that this doesn't resonate for you in as individuals or in Australia, but certainly in the UK, where there are perhaps at different times more practitioners than patients in different areas, people feel a bit competitive and unwelcoming when colleagues arrive in their district and set up practice, supposedly on their doorstep. But actually, we need to drop that and say we can support each other in practice. We can work as a team. How can we promote ourselves as a group, in the area, and actually work together in that way? And peer supervision is one of the avenues where we can get out of that, competitive element of, I'm not going to talk to you because you're going to reduce my client base, but I need to talk to you to find out how we can offer naturopathy more successfully together in that area, so more patients will come for all of us. So different, that being positive of the outcomes of our work is another area that we often, perhaps are overcritical of what we do, because we have very, very high expectations that we put on ourselves. So looking at other professions, they need supervision, and they report in various studies that they're satisfied with supervision, and they often voluntarily opt for more supervision than they are formally required to. Certainly in Europe, some professions like acupuncture are required to have supervision. In others it's voluntary, in others it's not really formalized within the culture. So it's interesting to look at other professions where supervision is built in and it actually benefits the profession. And one of the reasons, a second, third, fourth dimension for why supervision gives us that very useful second eye that Kimberly mentioned, is that we're all passionate about what we do. For homeopathy, it's set out in the guy who founded homeopathy. In the first sentence of his opening book, it's our high and only mission, and that for most homeopaths becomes very single-minded and very passionate. And I think we need to kind of, again, recognize that passion, because it is the driver. And again, Alistair Gray did identify the 12 homeopaths in the study in New Zealand and Australia all said, yeah, we're passionate about what we do, and that passion is a driver. It's a positive driver that keeps us doing what we do. But we also need to recognize that passion can slip over into prejudice and extremism. Okay, that's a bit of a challenge for us, because we're all very nice people. We have very, good motives for what we do. And I think where I find CAM practitioners, where the passion is a negative as well as a passion being a positive, is that it actually puts a bit of blinkers on us where we actually forget to pay enough attention to the needs of our individual patients, and we're not practicing patient-centered practice, but we're practicing, say, TCM-centered practice or homeopathy-centered practice, where we're putting the treatment over and above the fine-tuning of listening to what the needs are for that patient in the room. That's a bit of a challenge, and I'm happy to, if we've got time to discuss that later. But one example, two people having a disagreement about a political matter in the profession, and the neither of them gives way, and first homeopath, second, you need a remedy. Okay, so we think that a treatment is going to cure something that is a difference, or a difference of opinion. And interestingly, although we all believe that we are positively motivated, we're passionate about what we do, fine-tuning communication skills, again, a study came up with both doctors and practitioners noting that all of them fed back to the researchers that they didn't believe they had enough education in communication skills, which is an interesting one for CAM practitioners, because often we think, yeah, this is what we're really good at. We communicate well. So it wasn't just the doctors, it was also the CAM practitioners who came back and said, yeah, we need to do some more about, fine-tuning our communication to really make sure that the patient is making an informed choice about the modality that they're opting for. And I think, again, another commentator, someone who's an educationalist, has studied the patient-practitioner relationship in clinical training. And what she came up with in interviews in CAM practitioners is that very often that we believe that what we do is special. We feel passionate about it. We have hugely positive intentions. And to some extent, patients feed into that because they're making a definite choice to come to a complementary therapist rather than go to their doctor. So they're making an active choice to seek complementary medicine. And, there's a bit of fudginess that can happen between our own good intentions and patients' compliance. And, fine-tuning our communication means that we don't take it for granted that the patient understands everything that we explain to them, that they really are making an active and conscious informed choice, and that we can check that out and evaluate it, at regular intervals, and review treatment at regular intervals. And that's where using patient feedback forms, can formalize that very constructively. So, yeah. So coming to the toolkit, I'm a bit aware of the time because I can talk away for, the hind leg off a rabbit. Mixing my analogies here.
But so it's communication skills.
Yes, thanks, Raleigh. So the toolkit. So the practical way of how to set up a peer supervision group, and that fundamental frame is that we're all peers, no matter how experienced we are, whether we're a student, whether we're new in practice, or whether we've been in practice for 20 plus years. We're peers, so we're all equal in this group. We've all got something to learn. We've all got something to give to the group. And I'm using an Australian coaching supervisor, 7 factors that she thinks are fundamental to setting up peer supervision groups. And the first one is that everyone is equal. We're peers. There's no particular expert who will tell us what the answers are. It's a supportive structure. It's also structured in that the peer group can agree to meet once a month, once a week, once every 2 months, whatever works for the group, and that whatever that agreement is, everyone attends. So, and I know distances in Australia can be a huge aspect. And again, another study has shown that peer supervision groups can actually work online on Skype just as effectively as meeting face to face, which is an interesting one. So also, if you agree as a group of peers to meet for 2 hours or for 3 hours or 1 hour, whatever works for the group, you use that time for supervision. You use that time to actually actively delve into your professional practice. Bottom line, you don't use it for gossip or the cup of tea or the, yeah, how's your family? All of that is important and all of that has its place, but just use that time for supervision. And it is actually self-directed, so you're all in charge. And that anything that is discussed in that group, in the peer supervision time, is contained in the group by the group. So there are no subgroups, there's no gossiping about what happened in the supervision session afterwards, and no telling a friend who's not part of the group, oh, did you know about Jane? She had this terrible case. So that agreement about confidentiality within the group, which is based on that trust, that sense of affiliation as a group, so that you can use the time constructively. And although we're all involved in talking about, talking with our clients, talking about our practice, sometimes using time non-verbally is also productive and constructive. So you might choose as a group to say, okay, next session, why don't we draw? Why don't we take the time to actually write about something that happened in practice, or to take some modeling play and actually do something with your hands instead of immediately sitting down and talking about what happened in practice, and then coming back as a group and talking about what you've drawn, what you've written, or what you've made. So use your imagination and use other creative techniques in the group. So the groups, Ali suggests that they should be self-funding. If you're meeting online, costs are going to be minimal or none if you've got free access to internet conference calling, which Skype does offer now, non-subscription. If you're meeting face-to-face, if you're meeting in a neutral space, that you all pay equally for the rental of that, so that, again, no one person is in charge of organising, renting, inviting. And that
Zofia, looking at those different ways to meet, is there, it's different for people, and sometimes, yes, you have to use technology, like exactly while we're on webinar tonight, because everyone's really busy, and you do a webinar program so people can access it. But do you have a preference, if you can, of
No, I think it's very personal to the group, and I'm a what I'd call an experiential learner, and I love what happens in a face-to-face group, because but that's very personal to me. And what was interesting was to read the study, which was looking at supervision offered by the internet, using Skype conferencing or GoToMeeting conferencing, that actually some of the practitioners said that they actually felt more able to talk about something personal, something that they really needed to talk about. They felt the impersonality, to some extent, of the remote connection allowed them to be more personal than they would have been face-to-face. They would have been a bit more reserved face-to-face. So it's very personal. I don't think there's there's not one thing that's going to work better. So much
Sure.
depends on what the group wants.
Yeah.
Um,
I had a couple of responses in regards to forming the groups, like
mm,
how do you choose your peers? I mean,
yeah,
obviously, it could start from when you went to college and university together and
yeah, yeah,
progressed through, or I mean, are there other
yeah,
ways,
yeah.
or
Or
what's
it's
your
it's
thoughts?
meeting on, you know, uh, I don't know if any of you use like Facebook forums, or there are closed groups that you can set up on Facebook where you can put a note out there and say, I want to start a peer supervision group, and see who comes. Put an ad in the clinics, talk about it to colleagues. There are so many different ways of doing that. Actually looking up, the register and finding out who is on your doorstep. I don't know if Endeavour has an alumni intranet. Do you have a messaging forum that
F for alumni or
yeah,
for
for alumni or and for students?
uh, we're
Is it?
investigating, like
Mm,
we do have a LinkedIn account which I did try to create for that avenue, and I think it definitely needs a bit more topical issues added to that to make
mm,
people,
mm.
because it's not just having a peer group, it's like how to engage with everybody. So that's something that I need to
Yeah,
focus on. So
yeah, yeah. But I think for many people, it'll be a question of finding, if you're different, if you're meeting online, there may be a way of contacting people, looking up who's in your area, or just checking out who's around, who's interested in joining a group, and then agreeing as a group whether you're going to be a closed group for 6 months, whether you're actually going to appoint someone who's going to chair the group for a while, who will offer some leadership, or whether it's more fluid than that. And again, there's no right model to it. It's whatever you can agree as a time, as a group at the time, and say, this is how we're going to structure it for the next 6 months or for the next year, and then we'll review it and
sure.
how you're
Where
going
it's
to work. Yeah,
Yeah, I
yeah.
see where you've got dyads and triads still to go. I've just got something in maximum number. Is there like a preference to how many people should be involved
Yeah, no, I
in the
mean,
peer group?
yeah, some people, like I know some colleagues of mine who said that they've been working as a group of three, which is this
Mm,
triad model that I'm going to talk about now. And actually, they've been a solid group of three for about 15 years, which is, I think, pretty unique. So, you know, 6, 7 is often a reasonable number, because it gives everyone the opportunity, depending on the time that you agree to meet, to actually feel that they have a voice, that they're heard, that they 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 actually work constructively in that time. With some, it's smaller, but I think more than 6, 7 would be trickier to manage timing wise, to make sure that everybody actually got what they needed from a group meeting, whether it was remote, on via the internet or face to face. But that will so depend on the people involved. That yeah, does that make sense?
absolutely, thank you. Yep.
Yeah, yeah, yeah.
And
So working,
if
yeah,
anybody's got
go
any
on.
comments while we're answering that, please put them in. We're in the wind up stage, so if you do
Yeah,
have any questions that you want to ask, please definitely write them down, and I'll put them to Zofia before we finish.
yeah. So working in triads is a formalized, structured way of setting up a group of three. So you have someone who is talking about whatever is the giving the case, talking about the incident. And you have someone who's receiving the case, so the listener. So you have the case giver, the listener, and you have a third person who is the observer, who describes what they notice in that interchange. And you agree timing of that. So often it's 3 slots of 10 minutes. So somebody talks about what happened in clinic, somebody listens, so the 10 minutes is uninterrupted giving the case, then the listener has 10 minutes to offer feedback on what they observed, and then it then shifts to the observer having 10 minutes to describe what they noticed happened between the first two people. And it's that uninterrupted 10-minute listening space, talking space, that actually something quite unique happens in that time, where then you can often allocate another 10 minutes to the session where you all kind of more informally debrief. So starting then with the person who described what happened in clinic, they say, oh my God, that was really useful because the way you listened to me, I was able to clock that, or that the way the observer gave me feedback of what happened, you know, that's something else clocked for me. So that's, it's actually it's a tried and tested formula, and it's often really, really useful to experiment with that formalized working triad structure in peer supervision. So yeah, I will just go on to, I know we're closing, that whatever you decide as a group, that active agreement and discussion about how you're going to use your time is the kind of the framework of the like skeleton of the group, the support mechanism that formalizes how you use that peer supervision time. And yeah, that way of looking, that seeing the world through someone else's eyes, whether it's a patient or a peer. And I think the Namadajira project in Australia, working with Aboriginal artists, talk about ending invisibility. So that storytelling makes them visible as a part of the community. And I found that very inspiring in terms of what peer supervision can offer us, or as the contemporary philosopher Leonard Cohen says, reflective practice, I often see it as the crack where the light comes through. And these rocks up north of Broome I find very powerful in terms of, oh yeah, there's the crack and there's the light coming through that peer supervision shows us, gives us that opportunity to shed light on where we need to discuss and learn, evaluate and grow in practice. So just on time, thanks for listening, and thank you very much for your contributions.
Thank you so much, Zofia. There's so much information in there, and I think some of it makes sense. And we go, oh yeah, I am doing that, or that's they might not be, people might not be recognizing, as you said, like catching up with someone for a coffee. They could be doing that as a more of a friendship, and then but unknowingly having a the peer session. So, has anyone got any questions for Zofia while we're just closing this up? I'll just wait for them to come in. I have got a few questions that people asked that I was just holding. So, in regards to the feedback, so in the you've got the 3 10 minutes. Is there a typical type of feedback you'd expect people to make during those sessions? I know it's different, but just to give someone a guideline, some guidelines of the type of feedback.
I think, this comes back to the kind of trust that you have as a group, and going back to the competency standards that talked about giving and receiving feedback non-defensively. Giving feedback needs to be non-critical. It needs to be constructive. So it's oh my God, you really messed up there. It's not that. It's okay. Okay, you've acknowledged that was a tough one. Can we find a way through this? What would help you, or have you thought of? So it's being constructive, so that you're all working to what we will all kind of learn from as practitioners. And I think that trust and the understanding that you're offering constructive feedback, are very useful.
No, thank you. That's good. Um, I've just got another one in. So it's, aren't some people better at seeing things more objectively than others, or is there a way around this?
I think that it's exactly the peer supervision, or however you formalize it, actually gives us all the opportunity to 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 improve our capacity to be objective, our capacity to critically evaluate what went on, and that's not the same as being critical. It's actually giving us the formal opportunity to step out of what happens day to day and improve our our skills in those areas.
Okay,
So yeah,
great.
we'll all have our strengths and weaknesses.
Mm,
We're all different, but there are ways there are techniques that we can use where we can all evolve in our understanding.
So are you saying it's a practice that we practice, and as we do, we improve with supervision and reflection? Is the
Yeah,
next question.
yeah. Yeah, and I think that's what all the professions that where supervision is formalized recognize that it allows that evaluation and yeah, so that we can be more fully aware, more present with our client the next time somebody walks through our door.
Okay. Thanks for those questions, everybody. I know we're just starting to extend our time here, so I realise everyone wants to go and reclaim their night.
Yeah,
I do have one other question I wrote down from earlier. Um, I'm just finding it in in the boundaries side of things. In when you're forming it, because you're talking about informal and formal. Have you experienced any difficulties in setting the boundaries, or um, I'm just
yeah.
paraphrasing this?
Yeah. I think the confidentiality aspect is very important, so that you know that if you talk about a case during that peer supervision group, somebody in the group isn't going to take it out beyond the group to colleagues, or that, I mean, even a worst case scenario has happened where you've walked into a cafe and found somebody talking about your case to a colleague or a friend, which has happened, where, we all get or, it's possible to get a bit loose in our boundaries. So that agreement, yeah, really now does need to be formalized, and the trust established that it will, anything said in the group stays in the group and doesn't.
I guess we just take it as another session, client session that's
Yeah,
got the
yeah.
confidentiality when we
And
see someone,
apply
so we
those
just,
the same ethics,
yeah,
that we all are bound by our association's code of ethics and
absolutely. Um,
confidentiality.
I've got another one in. Are there questions that are really important to ask? For example, what are someone's expectations before analysing, reflecting when we do this supervision? So I
Yeah,
guess it's the,
yeah, and that's part of the contracting process that you'll do as a group. It's like, okay, yeah, what do each of us expect from peer supervision? And if you can have that discussion as a group, then you'll be clearer about what your needs are as a group. So sometimes having that discussion at the beginning when you're forming can be very constructive and feed into how you decide to organize the group. Yeah.
sorry, and it was that one was more from the client to
Ah,
um,
okay.
then
Yeah,
reflect it on the
yeah,
group,
yeah,
on it in the
yeah,
group.
yeah. Client text. Yes, I think that's a really good question, because often, a patient will come through the door and say they've got, aching knees. They're not necessarily interested in, that whole case scenario. I know homeopaths often go into what they want to see is less pain in their knees. And yeah, you need to be very clear, yeah, to ask the patient what they want from their treatment and to keep that in view. Is that what you asked? Is that what you meant?
Yeah, I think is
Yeah.
we'll get another. Um, I asked because I found that clients were expecting something different to what I could provide, and then I'd
Mm.
analyze incorrectly.
Yeah, yeah, yeah. And I think that's what I was talking about being patient-centered. It's like, yeah, listen to the patient, ask them what their expectations are at the beginning of the session. And I often find it useful to build in a review session. If I take on a new client, I say, okay, we will begin treatment and we will review it. And depending on what the scenario is, perhaps in a month or 3 months' time, we'll actually have a formalized review session where I'll ask them where they think things are going, do they want to continue with treatment, and so on. And different people will manage that differently. But yeah, keeping the center, keeping the patient's needs at the center, not taking
Yeah,
it
and
for granted.
that was definitely a strong focus. It's something that I've taken out of this session. So yeah, thank you.
Yeah,
Um,
yeah,
that's covered off all the questions that I have, and I haven't got any more coming in at the moment. So, um, Zofia, are we able to, if I receive any more questions, are we able to send them to you at all,
yeah.
or are you
Sure,
okay?
no,
So,
that's welcome. Yeah,
s- so if after tonight you've got some other questions to ask, please send them to myself, and then I can get in touch with Zofia and we can take it from there. For me, I want to thank you so much for making your time available, even though it's the start of the working day over there. So I hope you have a really great day. But thank you for
yeah,
enlightening us with your knowledge on the peer support.